Hi, I'm Dr. Hajer Mohammed Abd ElHamid, Assistant Lecturer of Endodontics. We will talk about the silver cone, which is a part of the obturation lecture. We talked about the gutta-percha, and we will talk about the silver cone as it was used earlier as an obturating material. What's the composition of silver cone? It's 99% silver, 0.04% nickel, and 0.2% copper. What's the properties of silver cone? The silver cone is like a needle. It appears in radio opaque in the radiograph, and it resembles the needle exactly. The properties, it has high hardness, high tensile strength, and oligodynamic properties. What the oligodynamic properties? It's the ability of the silver to kill bacteria. And not the silver only. Many metals has this ability, like the copper, iron, mercury. It has the ability to attack the cell wall of the bacteria and kill the bacteria. But the problem is the corrosion potential of the silver. And it has toxicity. So nowadays they are using the silver in a nanoscale, nano silver particles, to overcome the toxicity of the silver and the disadvantages of the silver. So they are using nowadays nano silver to take the oligodynamic property or the property for killing the bacteria from it and eliminate the disadvantages of the silver. The silver has a very bad adherence to the surrounding dentine of the root canal. Like this picture, we will see now that the silver cannot adhere to the all parts of the canal. And here in this picture, you will recognize that there were, or previously or in the past, they were not doing so much cleaning and shaping to the root canal, and that's why they are just making a slightly cleaning and shaping and inserting. Due to the high hardness and high tensile strength, they just insert the points to the root canal. And here we will see that there is a part, it's not obturated in the root canal, so it doesn't fit the shape of the root canal. So what's the disadvantages of the silver points? Inability to conform to the canal shape, what we said before. We can't put so many silver cones in one canal. The technique which was used before, that single cone technique, just one single silver cone in the root canal, so it's not a very good technique in obturation. Corrosion, the corrosion products occur after some time in the root canal. And when you see a previously treated tooth with silver cone, which is now rarely, very rare to see it, I saw once when I was student. The corrosion product, when you retreat this tooth, you don't see a cone, you will just see a corrosion product, and it will be like stain on the walls of the root canal, and then it degenerate and make a periapical lesion due to inadequate or bad technique of obturation and inadequate hermetic seal, like we said before in the beginning of the obturation. Irritation to the periapical tissue, yes, because the byproduct make irritation to the periapical tissue. Lack of dissolvability, it doesn't dissolve in any solvent, so they were just leaving us a tip in the pulp chamber that when we want to do a retreatment, we just pull it from the root canal. Post and core building up become impossible. That's it's obvious because we cannot insert any post in a root canal in its silver cone. Oh, it's a metal-like cone. Apical surgery become more complicated. Yes, we cannot do any apical surgery in this case. It's very complicated. There is no any hermetic seal in the periapical third, so we cannot do any surgical or apical surgery to the tooth. Corrosion product which cause argyrosis. What's the meaning of argyrosis? That's mean the byproducts of the corrosion products make a persistent stain in the tooth and the surrounding structure of the tooth. So this persistent stain will be in the tooth structure and in the periapical area, and thus make a periapical inflammation and induce the resorption. Silver cone obturation cause micro leakage. Why it cause micro leakage? Because as we said before, there is no any hermetic seal in the root canal, so it doesn't fit the shape of the root canal. It doesn't adhere to all the dentine in the 3D part of the root canal. So then there is micro leakage, and the corrosion products cause inflammation and pain. And obviously after the periapical lesion, which you can see here in the x-ray, there is pain. More pain can also occur after lateral condensation when compared to a single core technique. Yes, there is, if we do a lateral condensation, usually we do the lateral condensation in the gutta-percha, and we do a single cone technique in case of the silver cone. If we tried to do a lateral condensation using a silver cone, it will be so painful and it will be impossible. So as I said before, the single cone technique is used with the silver cone only. This is the shape of the silver cone, and this is this is the part which I said before that it is we can leave it in the pulpit chamber, so we can pull the silver cone from the canal from this part. If this part is not present, so we cannot remove it easily. But if we just wind in and make the flaring and make a very good flaring to the coronal part, we can just remove this. And look, the corrosion on the surface of the cones. Second thing, we will talk about the pasts. Now, solvent alter the gutta-percha pastes have been also used as the chloro-percha and eu-percha. We said before that we use a solvent like the chloroform, so we can just, instead of chloroform, because it is toxic, we can use chloroform or eucalyptus. So when we dip in the dappen dish, when we dip, we put solution here, our solvent in the dappen dish, and we just dip the gutta-percha in it, and it will be plasticized and solved. So when we dip it in a chloroform, the product will be chloro-percha, and when we dip it in a eucalyptus, it is called eu-percha. Sealers. What the type of sealers we use in obturation? Zinc oxide isonol sealers, epoxy resin sealers, polyvinyl sealers, and silicone rubber sealers. The first sealers introduced in the dentistry was the zinc oxide isonol sealers, and we will talk about a while later. Now we will talk about the ideal requirements and characterization of good root canal sealer. First thing, it must be tacky, and when we mix it, provide good adhesion when set between the solid cores and the canal. What's the meaning of this? What's the meaning of tackiness? Tackiness means that it is sticky. It's sticky. Why? To have the ability for good adhesion, to adhere the cones together and to adhere the cones to the wall. So it must be tacky for this reason, or it must be sticky for this reason. If it is not sticky or tacky, or it's a solid part, or it's heavy or thick, it will not have this property. So the better property is to be tacky and has a good adhesion. When we did previously the mixing of the sealer, and we said that the drop out test and the string out test and the drop test, we said that it must have this string to make a very good consistency. I have another video about the adequate consistency of the sealer, which is important, about the string out test and the string out test. So if it's not tacky, when you do the string out test, it will not stick, and it will not make the string which we talked about before. It should be or it should make a hermetic seal. What's the hermetic seal? What's the meaning of hermetic seal? The meaning of hermetic seal is tight seal. So when we use this sealer to fill the gaps and to adhere the solid cones together and to the wall, it must be there is no spaces, and it make a very good seal in the root canal, all over the canals, and prevent any spaces or any parts that it's not wettable with the sealing solution or sealing root canal sealer. It must be radio opaque to see it in the radiograph. Particles of powder should be very fine. This is a very important part. We said before that the sealers, it has two types, a paste type and a powder and liquid type. In the powder and liquid type, how we know the very good powder or the very good sealer from the bad one? because nowadays there is many companies producing various kinds of sealers. When you see the powder of the sealer, the particle size must be very fine. And when you make a mixing, the particle size must dissolve. If after mixing you see the particle of the powder, that means that this is a very bad sealer. If the particle size is so big and it didn't dissolve in the solution, so this is a very bad sealer, so you have to take it aside. So it must have a very fine particles to be dissolved, because also when you make when you use this sealer or this bad sealer, the particle size will stay and it will not dissolve, so the particles will stay inside the or between the cones and inside the root canal, and it will not make a very good adhesion. It should not shrink. That's obvious, because if it shrink, there will be a micro leakage, and then it will have there will be a periapical lesion. Don't stain. That's also obvious. It should be bacteriostatic, insoluble for also micro leakage, tissue tolerant, because some sealers go out from the periapical to the periapical tissue, so if it comes out to the periapical tissue, must be tissue tolerant and doesn't make any inflammation or irritation to the periapical tissue. Soluble in solvent in case of retreatment. Set slowly or ample working time, so we can work not in a hurry, so ample working time is very good. Don't provoke any immune response in the periapical tissue, and of course not mutagenic or carcinogenic. Function of root canal sealers. What's the function of root canal sealers? Antibacterial effect, which is very important and very important part. There is many sealers now for this part, antibacterial. Some sealers now in recent papers, now we can introduce nano silver particles to make the antibacterial effect, some medicaments to the sealer to make the antibacterial effect, so it must have this antibacterial action. Fill in the discrepancies or the gaps between hardcore filling and dentine wall. Like we said before, we have to fill all the parts, and it doesn't leave any gaps or spaces between the cones or the cones and the dentinal walls, dentine walls, without any filling. Lubricants, it lubricates the walls and the cones, and radio opaque. The first sealer is zinc oxide igenol based sealer. Sealers, the main ingredient in it is zinc oxide igenol, like Rickert sealers, Watchet sealers, and Grossman sealers. I don't want from you any details. I just want you to know the sealer and the examples and the names of the sealer only. I don't want any composition, and I don't want anything, just the sealer and the examples for it. The zinc oxide igenol sealer, it has an antibacterial effect, ample working time, and the disadvantage has inflammatory reaction due to the igenol when it comes to contact to the periapical tissue. Medicated zinc oxide igenol sealer. When they found that the igenol makes some irritation to the periapical tissue, so they decided to introduce a medicaments in the zinc oxide ethanol sealers like indomethacone, Sargenti formula, and the spade. This is the example. They just put medicaments in these kinds of sealers or zinc oxide ethanol sealer to make it more anti-inflammatory sealer than the previous zinc oxide ethanol. Calcium hydroxide sealer, non-ethanol sealer. Here there is no any ethanol in the sealer. The previous one has a very tiny percent of ethanol and they put the medicament in it. The calcium hydroxide sealers like the C-Lapex or the CRCS, calcibiotic root canal sealers. It's a very, very nice sealer. It has all the advantages and properties of calcium hydroxide, so it's a very good sealer. Its advantages high pH, so it's antibacterial, high biocompatible. There is no any inflammatory, or it doesn't make any inflammatory reaction. But the disadvantage is its solubility. And look here, it comes in a paste form, not a powder and liquid form. Also here in the previous one, it comes in a paste form. Resin sealers. The resin sealers like the epoxy resin. What's the example for the epoxy resin? The diakit, AH26 and AH+. It's like this picture. It's two pastes. We mix it together and then we make we use it for the obturation. It's a very good sealer. But the disadvantages, or let's say the advantages before, it's high dimensional stable, there is no shrinkage in it, high radio opaque, but the disadvantage sitting shrinkage, and it has some slight of formaldehyde. What's the sitting shrinkage? It's dimensionally stable, and it has a very, very slight shrinkage during sitting, but it's not recognized. It doesn't has any harmful effect on the sealing ability. These are many types of sealers in the market. You can just use anyone you want. The methacrylate resin-based sealer. The methacrylate has many generations. The first generation was the hydron. The second generation was the endurase. The third generation real seal, and fourth generation real seal SE, and the meta seal, which is very nice. The fourth generation is very nice. Then they used the glass ionomer sealers, like the glass ionomer capsules which you use in the operative. They made glass ionomer sealers in a capsules like it, and they call it the Kitak Endo. It is a very good sealer, adhere to dentine, very good sealing ability, low shrinkage on sitting, but the disadvantages is difficult to retreatment. It's very hard and the low opacity, so we don't usually use it. Okay, now we will talk about the techniques in other video, and we will just end it. This is the sealers. Like I said before, it's very important to know the sealer, an example for each sealer only. I don't want you to know anything, the advantages and disadvantages for each sealer, only the composition or any other details. It's not needed now. Thank you.